next talk about the point of care diagnostics, we have Dr. Ajay Padke. So due to last minute commitment, sir is not able to join, but sir has recorded the video and sent to us. Just a short intro about sir. Sir is currently managing SRL Padke Labs as head and consultant pathologist. The lab has over 20 branches and 100 plus collection centers. The lab was started in the year 1965 by Dr. A.M. Padke. The lab processes over 10,000 patient samples daily, including tests for infertility, autoimmune disorders, and others. Sir did his MD pathology from St. G.S. Medical College and Chem Hospital, and he's trained in autoimmune diseases. With this very short intro, I'd like to play the video of Sir, which is about point of care diagnostic technology. Batul, kindly play the video.
Hello everyone, my name is Dr. Ajay Padke and I'm here today to speak about point of care diagnostics. Thank you for IMA Tamil Nadu for inviting me to speak at this August forum. One of the most important things which we have to understand about point of care diagnostics is that it's always evolving, and what we see today may be completely different, say 1 or 2 years down the line. So my lecture is going to comprise of a few basic sections. I'll start with introducing what is point of care and then a few other sections. So let's start with what point of care really means. First thing is that it means that you have to test wherever the patient is located. The patient could be located at home, in the hospital, in the ICU, in an industrial area. So wherever the patient is located. So this testing usually takes place outside a clinical lab. And the testing itself takes place outside a clinical lab. So it means that it's not like a home blood collection where you draw it at home and test it in the lab. Usually this is done for any test where you need a quicker result, and the results have to be clinically relevant. It also means that this test can be easily run by a patient himself or even a very minimally trained person in a clinic or an industrial area. Another important factor of point of care is that the result which is there should not require much interpretation. It should be very easily discernible for an average person, either with the help of sight or sound. So here we're talking about the various places where point of care testing can be used: in the hospitals, in the clinics, in even concerts, stadiums, industrial areas, airports, etc. So there are a large number of applications of point of care testing. To understand point of care testing a little better, the first thing we need to do is understand where we are today in terms of the Indian diagnostic industry and where point of care really fits in. So what we need to understand is that, point of care is just one aspect of testing. The entire lab processing and the diagnostic sector is a very vast sector. So let's start off with what we know of a central lab, right? So if you take any of the larger labs which you have in India, depending on the complexity of the test, the location of the performing location of the test can change. For example, if you're talking about highly complex tests like cytogenetics or genomics, requires NGS or sequencing, then it is usually done in a lab. Many hospitals also have very high-end lab setups. So some of them are doing very high-end testing as well. For example, Hinduja, Breach Candy Hospital. The lesser the complexity of the test, that means that you don't need trained manpower to perform the test. So this test can then be done at home, assisted living, doctor clinics, non-medical facilities, etc. So this is the spectrum of testing which we have today. In India, most of the testing is done in one of these places, right? So if you have in home or offices or industrial areas, they can be tests which are done by phlebotomists, and they are sent to either small satellite labs or they're directly sent to reference labs. If you have doctors' clinics, some point of care testing may be done in doctors' clinics, but broadly it is either sent to labs and then reference labs. But in hospitals and ICUs, they do perform certain routine tests in the lab, the hospital lab itself, or in point of care in the ICU or in the emergency and accident department. Following which, if there's something more specialized, it ends up going to reference lab. So this is a broad overview of what we have. Now, let's start off with some examples, okay? So the first thing I want to talk about is at-home testing. So this is Many of you may know about some of these examples, but for those of you who don't, this is going to be quite informative. So the first thing is that I don't know if many of you are aware that a lot of fertility tests can be done at home. The first one is to check your sperm count. This is not yet there in India, but in the West it's used quite a lot. So this checks for sp10 protein and it gives you a count. So if the count is above 15 million, then the test and control band will be positive. So it's very simple. And if the test band is negative, that means your count is below a certain limit. Similarly, you have things like for testing your ovulation, you have a test for FSH, which is post-menopause. You also have a test for the other fertility hormones. So overall, fertility testing is quite commonly done in the West, and some of it is applicable here. What we do have definitely is the beta HCG or the urine UPT, which we can do at home. Then glucose monitoring. In glucose monitoring, we have a very simple thing, which is a glucometer, which all of us have seen. And now the glucose monitor will basically link to your smartphone, so your doctor can track your results. But recently, what has actually come up is continuous glucose monitoring, which is like a patch which you attach to your arm, and it with a small micro needle, and then it constantly transmits data to your smartphone. Now, people argue whether so much data is actually relevant and what do you going to do with this data, but this is what is currently happening. And how to apply the data is not yet very clear, and whether actually it will make any difference in the patient or the, if not necessarily a patient, but a person's health overall remains to be seen. Then one of the most common uses of point of care at home is obviously infectious diseases. Now you all know about the COVID antigen testing, which was easily available. In spite of the lower sensitivity, it was, if you repeat the test enough times, then it can make up for the lower sensitivity. You also have tests like a H. pylori test, which can be done at home. Apart from your infectious diseases, you have a newer digital sort of approach where if you do a urine test, you can actually dip the dipstick in the urine test and your phone can scan the dipstick. And then once the phone scans the dipsticks, it tells you, what your pH is, what do you have any bacteria, do you have any pustules, etc. So it's quite useful that way. Then there are other kits as well, which are for even for say albumin creat ratio and many other things which are coming up, which again need to be done with a dipstick and then scanned on your smartphone. So far, the FDA has approved a few tests for home testing, one of which is cholesterol, HIV, menopause testing, which is FSH testing, ovulation from saliva and urine, pregnancy, prothrombin, and vaginal pH. Apart from this, as of now, not many tests have been approved by the FDA. So the advantages of testing at home is obviously the convenience. It saves a lot of time. It is done in the privacy of your home. It allows people who would not be able to travel to labs access. It also helps in enhance patient management on a more real-time basis. One of the biggest advantage I would say is that it can enhance public health. For example, COVID again. Not everybody wanted to do, could get an RT-PCR done. So this was a very mass way of allowing testing. So if at all you come positive, then you know for sure you are positive and you should isolate at home. It also will help. Having a glucometer at home helps in the patient compliance as well for those who have diabetes. Then one very important aspect is improve patient safety. Now, what this really means is that if you're at home, then especially in an outbreak kind of situation, it will be helpful to do it at home. And as much as possible, you want to avoid going to a hospital setup when any outbreak is present. The cons are the same thing would be if a person doesn't actually do the test properly at home, then it would be a problem. It can give rise to either a false positive or a false negative result. There is no real quality control done on those kits. Are those kits actually stored at the right temperature at home? Have you kept them out in the sun? Have they become spoiled because of any reason? We don't know. Naturally, not all tests are available at home. We have a very small test menu as of now. So it's a very, very small test menu with a few tests. Now, if something goes wrong, you don't have anybody to call. If you get a report, you don't know who you can speak to about your test result. So that's another problem. There's limited support. Of course, now privacy, like I said, the advantage is that you're doing it at home. But if you're then scanning these results and putting them on a smartphone, then there is some degree of privacy concern where you have to wonder where your data is being shared. And so you should be very aware of where these applications are sharing your data. And then sometimes I have seen that people do not fully understand how to interpret the report. So even if they do get something like an albumin create ratio at home, they don't know what it means. And if it's 32 when the normal range is 30, is it significant? What are you supposed to do after this? It's not really clear. Now, in obstetrics, I would say there's a very, very important, utilization of point of care. It will come up in the next few years, especially. One of the most important things which I can think about is for preeclampsia. Now, preeclampsia affects about 8 to 10% of normal pregnancies, and it's something which is only diagnosed currently with the utility of, say, a blood pressure monitoring and albumin in the urine. And then of course edema and things like that. But there are now tests, and this is just one of them. But there are many tests even done in the lab, which is SLIT PLGF ratio, which if it is high, then you can actually diagnose the onset of preeclampsia with some certainty. Just like the SLIT PLGF ratio, we have what we call as the glycosylated fibronectin, which is this test here, which is made by a company called Lumela. Now, this will tell you whether the patient actually has preeclampsia now or not. It can be done between 13 to 37 weeks of gestation. The other obstetric important ones are any test to detect the rupture of membranes. And broadly, there are two. One of them detect IGF-BP1, and the other one is fetal fibronectin. So both of these are for the rupture of membranes. Then in diabetes, apart from glucose and CGM, you also have certain interesting things. Now, let's say for example, you have been diagnosed with type 1 diabetes and you want to know whether it is what type of type 1 diabetes it is. If you see, you can do insulin antibodies, GAT65 antibodies on point of care, which is quite good. And not just that, you can also do a C-peptide. So this is for type 1 diabetes. And for type 2 diabetes, instead of glyco-HB, which is a 3-month average, you also have certain salivary proteins, and they change with the glucose concentration in the blood. So higher the glucose concentration in the blood, more is the binding of the glucose to salivary proteins. So this is another device which is point of care, which has been developed for that. So if you see here, this is glucemia. This is the name of this test. Around 1 to 2 week average of glucose it gives you, as opposed to glyco-HB, which is 12 to 15 weeks. Now we come for hospitals and emergency departments, right? So there is a large spectrum of tests already available for point of care. I'm putting it up here. So right from cardiac coagulation, renal function, diabetes, you have immunoassays like you have TSS, thyroid, T3, T4, FT3, T4. You have tumor markers, infectious diseases, and a lot of other things. Even in the ICU, you have things like PCO2, HCO3, lactate, fetal methemoglobin, bilirubin, etc. So there's a large variety of tests available, and it is only going to grow every day. There are many such instruments which do some or all of these tests, right? So let's say, for example, you have instruments by Abbott which can check the lipid profile. You have the radiometer which can check. It was a circular image here. This is the test menu of that. Then you've got this is quite an important one, which is called alinity. So alinity will basically give you the same accuracy as you would get in the lab. They have a similar machine called as alinity, but it can be done in the lab. The same accuracy now it can be done in point of care. It has a very limited test menu. This is for CRP. CRP, of course, the biggest benefit of CRP point of care is basically to avoid unnecessary antibiotics. So there are a lot of such devices of point of care which are there for accident and emergency. These are just some of the examples which we have. So they're there in multiple clinical settings, right from the ICU to the emergency rooms, to home monitoring, to radiology clinics for contrast administration with creatinine. You have coagulation clinics which have PTA, PTT, INR, PT-INR, and they can even be done at home. Urine can be done in the physician's office. So there is a large number of point of care testing already there in the market today. In India, it's not as much as the West, but we have a lot of options available. If the cost, so the biggest problem here is the cost and the quality of the kits. I will come to that. So how do hospitals really select point of care? So what they usually were to look at is, like, for example, let's look at the unmet clinical need. So what is the unmet clinical need? For example, a radiology setup, which has to do a CT contrast, it obviously needs the creatinine. So they would want a point of care machine for creatinine, because as the most, for every patient, you would need creatinine. Similarly, if you have a cardiac emergency department, then you would need point of care for HS drop I, etc., HS drop D. So it depends on the unmet clinical need and how and where it is going to be used in the clinical pathway. Then, like I said, if you want to diagnose any woman who has preeclampsia at the time of admission, then you can do the estate PLGF ratio, or you can check for glycosylated fibronectin. Now, so if you start using this device in your hospital, how do you know if it is effective? The most obvious thing is that if a test was taking 8 hours earlier, like if you're sending that test to the lab, the most obvious advantage is that instead of 8 hours, it will take 1 hour to give you the report, or even lesser than that. That's one. The second thing is that because of early testing and on time testing, it can actually reduce the length of stay in hospitals. That's a very important point. And third, it can help to improve your overall workflow as well. And in this case, what happens is that the faster the results, you can actually move the patients away from the accident and emergency department into other departments. But one thing we have to ensure is that we have seen many places where we start using point of care. So the initial step is done very fast. But after that, what happens is that there is a roadblock and the patient is not actually transferred out of the accident and emergency department on time. So it nullifies the benefit of the quicker testing. So these are some of the benefits. The time to get the result is shortened drastically. If you need IV contrast CT, then obviously to complete the CT scan is much quicker. It's much faster, if you can see here. The benefits in hospital settings, of course, rapid results, reduced length of stay, reduced cost because of reduced length of stay. The patients are also happy because the reports have come on time. Patient safety is better, especially if you're going to isolate, say, C. diff in the ICU. Then you want to isolate that patient, or so it improves patient safety. It helps public health officials to keep track of any outbreaks, and also it's easier to sort of have point of care accessible in ICUs. So you can actually increase your menu depending on where you are placed and what kind of patient makeup you have. Some of the other benefits are time to result can just be in 10 minutes for cardiac tests. Yeah, I've already spoken about the median length of stay is reduced drastically. CRP, I've said it can reduce antibiotic prescribing that in the index consult. And apart from that, there are other advantages as well. Now, the next point of care I want to talk about is molecular diagnostics. Now, we know that there have been a large number of lateral flow assays like the one which we have for COVID already present in the market, especially in the Western world. Like for pediatrics, over there, 10 to 15% of cases actually strep A. So they have a point of care, a lateral flow assay for that, even for influenza. So now what is happening is that some lateral flow assays, infectious diseases are now moving to molecular diagnostics, especially in the last 5 years. So this was the earlier one, right? You have lateral flow assays here. It can give you results in 15 minutes, but the problem is that the sensitivity and specificity is quite poor, and it has a very narrow range of targets. On the other hand, you can always send the specimen to the lab. Now, nobody does viral cultures, but for a routine RT-qPCR, it would take about 8 to 12 hours, not 24 hours necessarily. And then the reports have to be told back to the treating doctor. So very high sensitivity and specificity, but the TAT is quite poor. That's why molecular diagnostics is important, because it can give you the report in 30 to 60 minutes and not at the cost of quality, which is the sensitivity and specificity still remains quite high. So these are just some of the examples again. Sexually transmitted diseases is also coming up, chlamydia. Molecular group A streptococcus has come out. Large number of respiratory panels have come out in molecular. So I'll just show you some of them. You are probably familiar with some of these already. This is the Gene Expert, which actually was one of the first molecular devices to come in India. It actually changed the way TB was diagnosed, because TB used to take weeks to get diagnosed. It didn't just tell you that there was TB, it also told you that there was drug-resistant TB. So this was a very important thing. Then you have the ID Now, which we all know was used at the airport to diagnose COVID. You have the Cobas Liat, which again does some infectious diseases, molecular diseases, but most of them actually focus a lot on infectious diseases. Now, some of them also have oncology, which is quite interesting. So for cancer detection, for breast cancer, bladder cancer, CML, and this menu is only going to expand. One of the Indian make is MolBio, and this is actually fully made in India, and they actually can give you run 10 to 12 samples in about 8 hours. They have a very wide menu now, apart from TB. This is the current menu. Some of the interesting things which I would tell you were malaria, dengue, chikungunya, H1N1, and of course these others. And the most exciting part is that they have a huge menu coming up in the future as well. Like right from non-infectious, so sickle cell anemia screening is coming up, and a lot of things like HPV, which is quite expensive usually, it will also be done by them. They're focusing on HPV 1618 and 1618 and other high-risk markers. So this is what has happened. So earlier in any infectious disease, you would take up to 24 hours because the sample would go for culture, right? Then molecular diagnostics started coming up and the sample was sent to the lab. That still took anywhere between, it depends, like I said, 8 to 24 hours. Then came single plex testing for molecular. So one test at a time, one disease or rather one organism at a time, let's say. And then came multiplex PCR, which actually changed the entire, way people approach infectious diseases. So this was one of the first ones which actually came. It was developed for Ebola, but now a lot of us use this. We're familiar with this in the ICU setups. It is one of the first ones which we use for what we call as syndromic testing. So if somebody comes with a suspected meningitis or encephalitis, this has a panel. This is a panel of 25 organisms, including bacteria, viri, etc. Same with respiratory. There are two panels in respiratory. One of them actually includes COVID as well. And GI, I would say, is also quite underutilized because we've detected a lot of C. diff cases because of this. There is cryptosporidium, and there is joint infection again for septic arthritis, which has a large number of organisms. So this is something in which you can do multiple organisms on the same sample within a matter of 1.5 hours. The good part is that when you're dealing with multiple hospitals like us, it also gives you like a trend analysis. So what is happening, in which month do you have what kind of infections, right? So if you see that obviously COVID, there was a, this is not necessarily SARS-CoV-2. There are lots of other different types of coronavirus as well, which causes like a common cold. So you can see the trend analysis. It helps the ICU intensivists to understand what is going on and helps them to plan their infection control strategy better. Now, in the operating theater, you have some of the examples which I can give you again. If you're doing a liver transplant, then during the anaphylactic phase, you need ionized calcium, which can actually reduce the load from transfused blood. This is done right now. In a cardiopulmonary bypass surgery, you need coagulation status by point of care. That's again important because it reduces post-op blood loss. Third is that intraoperative measurement of PTH during those parathyroid surgeries, and the success is actually much higher. And the fourth is thromboelastography for intraoperative bleeding. So these are just some of the examples of operative markers, a POC in the operating theater. Now, again, the cons, one of the cons again is there are limited test options. Not all of the tests are available in point of care in hospitals. In some cases, the accuracy is a concern, but with molecular multiplexing, that is less of a problem. Quality control, I would still say, is a problem. It has to be maintained and calibrated just like it would be in the lab. If you don't do it, it would be a problem. Besides, BioFire, GeneXpert, and these instruments are actually going to be either in the ICU or in the lab, preferably in the lab, but it's not yet reached the stage where we can put it in the doctor's clinics. But over a period of time, it will evolve possibly towards that. It also needs to enter some kind of quality control program to make sure that your results which you are giving are valid. It should be entered just like any lab would enter. One of the things which we cannot eliminate naturally are the pre-analytical errors. For example, if you don't follow the steps which are required, by the buffer addition, etc., properly, then it can lead to an incorrect result. So to summarize this, I would say that there are multiple pros and cons. It depends on the case, right? Now, in some cases, POC testing would be the appropriate choice, while in others, lab testing would be more suitable. So it depends on the test which we're talking about and the clinical scenario. So here is the specialty lab. We have all kinds of esoteric testing, which is of low volume. It may not be 24/7, and a lot of clinical expertise and interpretation is required, like cytogenetics, so flow cytometry, histopathology, all of these things. On the other spectrum, you have point of care testing, where you need fast stat, but not at the cost of accuracy. In the middle, you have stat labs and core labs. So now what happens is that what is an esoteric test today may become a point of care test tomorrow, depending on the clinical requirement. So, but does that mean that point of care will replace a specialty lab? The answer is no, because as these tests move into point of care, many more esoteric tests will be added in labs, like genomics and proteomics, which is a very, very rapidly advancing field. In India, our major health concerns are oncology, the rate of cancer, HFN and breast cancer are rising. Metabolic disorders and other non-communicable diseases are, of course, rising. Hypertension, diabetes, etc. And infectious diseases, as we know, is a major, major concern as well. We need a cost-effective, battery-powered, multiplex lab-on-a-chip device which can do infectious as well as non-infectious diseases in low-resource setting also, right? And it has to be high-quality results which are clinically relevant and comparable to standardized lab equipment. Because in the future, I feel, and most of the people feel this way, that personalized medicine will enter our lives where we have to tailor make a form of treatment for everyone, and there will be no one size fits all approach. So POC diagnostics is evolving with science. So all of us have to have an open mind and be on the lookout for what we can use in our respective centers. Thank you. If there are any questions, I'll be happy to answer them. Thank you.
Audience, if they have any questions for this session or for previous sessions, you please type in the chat box. We'll take it in the as we go.